today we are actually going to recap modifier 51 and 59, but we're going to go into a lot more detail than I did a couple of weeks ago. I listened and I went back over what I presented, and I felt like I didn't do it justice. To be fully equipped to understand modifier 51 and 59 is my goal, so that you're going to always have to question yourself. Coders do that. I don't care how experienced you are. These modifiers are found to be confusing. I want to eliminate as much of that confusion as I can. So we're going to go back over, and we're going to even cover a few things that you covered in your course, but you've not covered since. So now is the time before you start employment that we want to cover that and make sure you understand that. So that's the reason that I'm doing modifier 51 and 59 again. And we're going to go over the definitions one more time. Modifier 51 tells the payer, because you're putting these modifiers on the chart. When you're coding, it's going into a chart system, a billing system. So the payer will reimburse the provider or the facility, whoever you're working for. It tells the payer this information, that multiple procedures were performed at the same session with 3 distinct definitions. Different procedures performed at the same session, one procedure performed multiple times at different sites on our body. A single procedure performed multiple times at the same site on our body. All right, this modifier comes into play only when 2 or more procedures are performed. You will not assign modifier 51 along with an E&M service. So if you have an E&M and then you have a biopsy, this modifier 51 is not applicable. It's only when there's 2 or more CPT surgical procedures coded. Okay?
Yeah.
I want to talk about when it's not appropriate. It's not going to be appended to your add-on codes. In CPT, we know that we have add-on codes. I've given us an example down here to look at. Also, we know that modifier 50 bilateral we use on some procedures. You're not going to put a 51 there because your modifier 50 speaks to the payer that this was done on the right and left. When you have 2 physicians performing a procedure during the same session, modifier 51 is not to be used for, let's say you're coding for physician A and you're coding for the facility. Let's back up. You're coding for the facility. You're going to code those procedures, but they're not going to be appended with a 51 because they were performed by 2 different physicians, which you indicate in the billing system, because you know that you always put the physician that performed the surgery in your drop-down box. Okay. And then I gave you an example here of an add-on code. This patient had a paravertebral block of the thoracic spine with 2 additional injections. So you're going to code for your single injection first, and then you've got to code for that second and third with 64462, which is our add-on code. So a 51 is not necessary. The payer knows that 64462 is an add-on code. It's built in the system to show them add-on codes so that they know that we don't have to worry about that. And find a code. Certain codes have the symbol that they are modifier 51 exempt, meaning they don't apply. And I did not capture the entire code description here. My purpose was for you to see, and I hope you can see, right here is the circle with the 51 in it, and a red mark through it means that you cannot append modifier 51 to 35600. So that's another purpose of scrolling down in your find a code for all your instructional notes, because this is an instructional note. All these right here, and it would probably do each of us good to go in and look and remind ourselves of what all these symbols indicate and find a code. But what we want to know today is that this is 51. So when you see that with a code, you know that you cannot append modifier 51. Right. These are things that I want you to remember, because modifier 51 affects reimbursement. So that's important to know, because you need to remember where to put that modifier 51, because you're appending it when you have 2 or more procedures. So we'll look at each of these. It's used to identify the second and subsequent procedure. We've discussed that. The use of this modifier indicates that the multiple procedure discount is applied to the reimbursement. That's not something that we've really talked about, but that is something that I want you to know about. In your course, it's briefly mentioned, but now that we're stepping out and we're past and we're in a different phase of preparing for our career, multiple procedure discounts are what payers and providers, or payers and facilities, agree upon. It is what you know that you're going, as a provider, Dr. A knows that he will not get full payment for all 3 procedures performed. There's going to be a discount to the insurance company, but he knows that. This multiple procedure discount refers to the practice of reducing the reimbursement for additional procedures performed at the same session. It's important to remember that modifier 51 is added to the second and subsequent based on RVU order, not on the primary. It doesn't matter what the primary procedure is. And remember, primary procedure is defined as the reason for the visit. Just because that's why I came into the doctor and he decided to do something more, maybe a biopsy, and then he removed the tumor, then it's going to be connected, but the reason for my visit was the biopsy. So it's based on the RVU order. And remember, in Find a Code, you see that across your screen. And y'all are able to see the RVU, right?
Yes.
Okay, thank you, Eugenia. If I mention something that you do not have or you do not see in Find a Code, please let me know, because I'm trying to make a list of things needed for you all in Find a Code that you may not have. So anything, shoot me an email if you think about it later, if you identify it later. I'll need to know those things for you. Okay, here is an example, modifier 51. This patient had a colonoscopy, and at the same session, the physician performed an upper endoscopy. All right, so I've already coded these. We're not working on our codes today. We're working on our modifiers. So we have 45378 and we have 43200. When we look these up and we find our codes, we find that the RVUs are lower for the upper endoscopy. So we're going to code the colonoscopy first, meaning we list it first. And we list our upper endoscopy second because of our RVUs. And the upper endoscopy receives the modifier 51. All right, I have one more example, I believe. Yes. All right, this is an excision of a lesion performed at the same session with an intermediate repair. Well, there's two codes to be assigned, the 12032 and the 11600. Well, the RVUs are lower for the repair. So it's listed second with the modifier 51. These are procedures performed at the same session. All right, now we're going to get over to modifier 59. And this is where what we discussed in modifier 51 was kind of a recap. What we're going to cover in modifier 59 is new material that you probably haven't looked at since you were in the course. Well, first, we want to look at the definition. It's important that we look at the definition. Modifier 59 indicates that a procedure is separate and it's distinct from another procedure on the same date of service. It applies to different sessions or encounters, different procedures distinct from the first, different anatomic sites, separate incisions, excisions, injury, or body part. That's the definition for modifier 59. Once again, it comes into play only when you have two procedures. You're not going to use modifier 59 when you have E&M service and you have a CPT service. Where is it not appropriate? Both of these, 51 and 59, they are used to identify additional procedures performed on the date of service. Same date of service as your primary. The main difference is modifier 51 applies to procedures that may be more commonly expected to be performed. But that's kind of a confusing statement because how do you know what's commonly expected to be performed? So I want to help you there. I want us to look at some things. Do you remember in the course hearing NCCI edits? Anybody?
Yes, we are familiar with it.
Thank you. Oh, good. All right, so we're going to look at what they are. We're going to refresh our memory
Okay.
because we're going to actually go look at NCCI edits on the CMS Medicare website. All right, so this is some Q&As, and this I got straight from CMS from the website. But it explained it so well. All right, what are they? Actually, they were developed to encourage national guidelines that support correct coding and reduce improper payment. How do they affect reimbursement? The NCCI edits, they're code pairs that should not be reported together for a range of reasons. They prevent certain code combinations from being paid by Medicare contractors. And then how do we interpret the table, which is what we're going to look at. Column 2 are considered to be incidental components of procedures described under column 1, meaning they're mutually exclusive. Medicare only reimburses the procedure that's listed in column 1. Column 2 are not separately reimbursed. Is there a way to override that edit? Yes. This is where modifier 59 comes into play. You can use modifier 59 when a procedure or service includes 2 or more CPT codes that are bundled together in these edits. And this question is, when is it appropriate to break an edit with modifier? The CPT manual, if we look at the definition of modifier 59 as a distinct procedural service, it explains that modifier 59 is used to identify those procedures and services outside of E&M that are not normally reported together, but are appropriate under the circumstances. And then the documentation has to be sufficient for the payer, for the insurance company, Medicare, to pay for the procedure. It must support a different session, a different procedure, different site or organ, separate incision, separate lesion, separate injury, so forth, not ordinarily encountered or performed on the same day by the same physician. Okay, this is, I give you a definition of what anatomic site means in the NCCI edit world. It includes different organs or different lesions in the same organ. It does not include contiguous structures such as our nail or our nail beds, or the structures that are in the eye. Now, I want us to look at NCCI edits. I want us to look at how to find them, and I've already pulled them up, but you would strictly copy and paste. You would copy this. And I'm not going to because I already have. And then you would put it into your browser. And I'm going to bring it over here. And I'm going to show it to you. You're going to get to this page. When you put that in your browser, here you are. You're at the P2P, procedure to procedure coding edits. You're going to scroll down. And here are the links that you're going to look at. And I'm going to explain these to you. First of all, we're not coding for hospital. So we see that we're not going to be using these. But we do see practitioner. That's our physician coding. What we also see is we have a July 1st, we have an April, we want the most recent. So if I go to July 1st, I want to also pay attention to that all these codes are not listed in the same file. They're divided. So you want to think about the procedure that you're coding and see where it falls into these categories. This goes your 0001 all the way through your 25999. Okay. And I already have these pulled up, but I want you to see how they go from 26010 to 36909. When you put, I will pull this up and just to show you, let's walk through the steps. You're going to accept on this page. All this is saying that you understand the copyrights and the liabilities and the disclaimer. So you're going to accept that. All right. Then you're going to have a download on your computer. When it comes up, you can use this text. I don't find it user-friendly. I use the Excel. So I would click on that and I would open it up, which I'm not going to do because I do have a sheet open to show you all. But that is how you get to the edits. All right. Now there is a tool that I want you, and you're going to get a copy of this, and I'm going to send, which in the recording you're going to have this, but just for Leon's information, I will send this PowerPoint over once the session is finished today. But there is an instructional guide how to use the Medicare NCCI tools. I don't have that pulled up. What I want you to do is I want you to go to this, do the same thing. I want you to copy. And I don't know what that is, but we'll go here and borrow this. Paste and go. This is a booklet. Keep it on your computer. But I want you to take time. It's 18 pages. I want you to take time and work through this. It's important that you understand this. You're going to hear this. If you code incorrectly for the physician that you're hired for, and or his coding manager may come back and say, hey, this doesn't pass an NCCI edit. I want you to know what they're talking about. Because they may not come back and say, you should have appended 59 on this procedure. They can very well come back and say, it didn't pass the NCCI edit. So this is additional material that is very important for you in the next couple of days to read and review and research the tables. We won't have another session on this, but I am open to questions. So you know how to reach me. Each one of you know my email. Send me questions and we'll work through this individually.
Hey, Faye, one
Yes.
question that I have is, we have kind of a mixed group. We have 3 who have passed a certification exam, and then we have 2 that are still working and will have to retake the certification exam.
That's
so
true.
Is all this applicable to all of them, or?
Okay, I'm going to talk out loud just a minute. Each one of these will need it when they're hired. So do we want to wait and cover this with the 2 that are still studying at a later point? I can do that, Leon. And maybe that's what we need to do, not to overwhelm them. That's a good point.
Yeah, we don't want to overwhelm
And this
Mara
is
and Daniel.
yeah.
We want to get them over the bar, and then we can refine.
Okay. It's good for them to know this today. Today is definitely just extra in their knowledge bank. And so what we're doing today is fine, but to take the time to do this, no, but I'm making myself a note because when they pass that exam, I'm going to be right behind them, making sure they go back to this. Does that sound like a good plan?
Yeah, it does.
Okay. All right. Daniel, you feel a little relieved all of a sudden?
I've been okay all the while.
Thank you, Leon. Leon, thank you. Thank you. I appreciate that. Okay, so this is where you will come and you will read it and you will become familiar with it. All right, let me go back. Why did it take down my PowerPoint? Okay, so you're going to still have this information when you pass that exam, but I've made a note just to do a little brief reminder session with Daniel, you, and Amara. We'll just do probably just the three of us and Leon to recap some of this because I don't want you to not get the detail here. I'm not going to read this because I'm going to show it to you. In the table, it actually lists these indicators. What the main thing is, I want you to know how to look at this list of NCCI edits and to understand why when you put two procedures that are found in this table without a modifier, and you don't put a modifier on them, they're not going to get reimbursed. They're not going to be paid. Now, this still applies when you're in your practicum, when you're in the virtual internship. This will also help you determine modifier 59 because we have scenarios, cases in the virtual internship where you may struggle with, is it modifier 59 or 51? You may find this helpful. All right, so we're going to look at an example. Make sure I didn't, yeah. I want to make sure I didn't miss a slide. This is a gastroenterology example. We have a colonoscopy, a flexible colonoscopy with a removal of a tumor or polyp. Let's just say tumor as our first, as a code, as a procedure code. We've identified the 45385. Next, we also have to code the fact that the physician did a biopsy, same session. We're in the same session today. Colonoscopy with a biopsy is 45380. Remember, modifier 59 is based on a more extensive procedure that was in one of the definitions. Modifier 59 is only appropriate if two procedures are performed on separate lesions or at a separate encounter. So we can easily see here that 59 is applicable. But what I want to show you is the actual table. This is just a snippet. This is not, I am going to bring over the table just to show you, but I want you to look at 45385. Let's just go back. That's our colonoscopy with our tumor, and then 45380 is our colonoscopy with our biopsy. So we have 45385 in column 1. In column 2, we have 45380. We are allowed a modifier. We see here in this column, we have a 1, and 1 is described as allowed. That's why you've got to go, you'll understand it even after we finish today, but reading through that MedLearn 18 pages will help tremendously. So we see that the description here is a more extensive procedure. That is the rationale as to why the payer allows 59. So unless you append 59 to 45380, you're not going to get paid. Your provider is not going to get paid. These are two procedures, and your higher RVU is 45385. So you're going to append that modifier 59 to your lesser RVU, 45380. A biopsy is considered a less invasive than a removal of a tumor. One more example here that I have. I do have the spreadsheet pulled up for that. This patient has a debridement of a wound to the bone on the anterior lower right leg. He has a debridement to the muscle on the posterior thigh of the same leg. So same leg, two different procedures. The debridement code is 11042. That's a debridement to the muscle. And then the bone is 11044. The bone is deeper than the muscle, correct? So we're
Yes.
going, exactly. So that's going to be listed first with 11042 with modifier 59. It's a different procedure distinct from the first and a different anatomic site. And I'm hoping I can bring this over and it will stay pulled up, and it did not. You can do a search to find this. And so let me just show you what these tables look like. This is your column 1. This is your column 2. This is your, see if I can get it all the way to the top. This is a column that would tell you if you could put a modifier 59 or not, or if it's allowed, or if it's just not applicable. It doesn't need a modifier. It's okay that the two are coded. So this is what your table looks like. We had a little bit of this in our course, but not enough to be out in a world where they're going to throw this language at you in CCI edits. So that's just a view of the table. Modifier 51, one last question. This patient's admitted for a partial colectomy with anastomosis and a ureteropylostomy. Okay, Dr. Smiles performs the partial colectomy with anastomosis, and Dr. Newton performs the ureteropylostomy. They're performed at the same session. Is it correct to append modifier 51? No,
No,
because it's right,
different procedure, different.
different positions. You're correct. That's it. All right. There is some good news to all this in CCI edits, is that when you're actually employed, the tools that you will be working with, such as in Find a Code, when you're building a bill, when you're actually building the statement for the provider to bill his services on, when you enter these two codes, you're going to get a flag of some sort. Every encoder is different, but it is an encoder. You will have an encoder, and you may very well have Find a Code, but you'll be on a different screen than what you're familiar with. And it should give you a red flag, which will indicate to the coder that a modifier is needed. Will it tell you which one? Not necessarily. Some do, some don't. I cannot speak for that because I do not know which system you will be working on as an employee. But I do know that 99% of encoders have flags set up to provide for proper billing. So it'll be a learning curve, but it will be a welcomed learning curve because you will appreciate those bells and whistles. that are actually provided when you're working for a provider. Questions? Did today help clear up any 5159 issues as you're coding through the virtual internship? Do you think?
Yes, Faye, it does for me. It's a more clarification on when to use them. But let me also ask, the NCCI it works only on modifier 59, but do they have one for 51 also?
No, no, they're strictly utilized for 59. Good question. Thank you. And I don't see as much struggle with 51 as I do with 59. And like I said, honestly, all of you, it's a struggle for experienced coders when they're really extensive procedures and you're just questioning yourself. But the more that you apply and you code with procedures, the easier it does become. It doesn't mean you won't have a question in years to come. It just means it's easier. And you always have a resource.
Also on the E&M module, there is a particular scenario that we had different levels for the risk, the problems and the data. The element the problem was low, the data was straightforward, and the risk was moderate. And from the results we had low. And there's instructions that when they are of different levels, you code it to the lowest. You choose your E&M level based on the lowest components.
Okay.
I
Let's
don't
go
know,
back.
Fred, did you get that? But I don't really get clear on that statement.
Okay. Let's talk about that.
When you have an E&M on different levels.
All right. So that's straightforward. Was it none? Is that what it was equivalent to? There was no data?
Yes.
Or was, okay. So what the
Yes.
statement, okay. So the statement says 2 documented levels. And what that means is 2 levels that have qualified information. So what you have is you have a low and moderate. So you're going to go with the low. Did it assign the low?
Yes.
Okay. And that is because
Yes.
because in the straightforward, there was no documented data. It's talking about documented information. Minimal or none.
Okay.
So if there's none, then nothing's documented. We can't use that. When there's 3 different levels, we're going to use the level. We're going to use the 2 levels that have documentation if the 3rd level has none. If that 3rd level, if that straightforward did have documentation, you would pick it up and use it. But when there is absolutely no data, and you're not going to be able to use it. If there's no documentation, you cannot contribute that to your point system when you're counting what E&M code level to assign. It's based on the 2 documented levels of E&M. So if you have a low and you have a moderate and you have a high, that means you have documentation in all 3 levels, correct?
Yeah.
Yes.
Okay, then you're going to assign the low.
Yes.
But if you have a moderate, a limited, and none, you can't use the none because there is no documented information. You only are coding based on documentation. Because when you're doing your points, when you're writing down and you do straightforward or none, and there is none, and then you do the next, the low, and then the next level, you're going to go ahead and cross out that none. You can't count it because there's nothing there. So it just gets an X. Cross it out. It don't count in your points, in your grading, in your assignment, whichever term you use. So like I write down my 3 levels. So let's say that I just write down, I'm going to write down minimal or none. I would write down none for my first one because that's in my mind that I have no data. I have no data. Okay. And then I have an acute uncomplicated illness. So I meet low on my problems. And then I got a prescription drug management. So I know that I'm moderate. So I have no documentation. I go ahead and cross that out. Out of the 2 that's left, I'm going to use the lower.
So the one without data
Right.
shouldn't be considered at all.
Correct. If I have another patient, if I have an acute uncomplicated illness, I'm low. I had prescription drug management. That put me in a moderate. And then we made a decision with the physician today to have elective major surgery. Okay. That puts me in a high. I have 3 different levels: low, moderate, and high. I have documentation for all because I had my acute uncomplicated illness. It's documented. I have my prescription drug in my chart. It's documented how I got to moderate. And then my documentation shows that the patients decided to have elective major surgery. So that's a high. So I have to select my E&M level. And you want to go with high because they get paid more, but you can't. When there are 3 different ones, what does the rule say? The lower?
The lower.
That's a bummer too, because a lot of work put into that position if they're making a surgical decision. But unfortunately, that is the guidelines.